Okay, well, good afternoon, everyone, and welcome to teaching for today. I wanted to talk today about antibiotics and antibiotic resistance. Now, there's so many things you could say about antibiotics. It could go a whole lecture series on antibiotics alone, but I just want to try to convey the basics of antibiotics today and aspects of antibiotic resistance that, as pediatricians, we really need to know quite a bit about because it's a current and also emerging and increasing problem. It influences everyday practice, the fact that there's increasing antibiotic resistance. So you need to have a good idea of the mechanisms of antibiotic resistance and what the types of antibiotic resistance and what we do about it. So first of all, I'm going to just try to talk a bit about antibiotics and antibiotic prescribing, and we'll go from there. Eh? So this is what I'll talk a bit about. I'll say something about how antibiotics work and how we might choose the most appropriate antibiotic. And then I'm going to say, when you understand how antibiotics work, you can sort of also understand how resistance develops. And I'm going to say why resistance occurs and talk about a few different common types of antibiotic resistance, which we see in everyday practice. And then I'll say something about antibiotic stewardship along the way. So that's the sort of overview of the talk. Eh? I think it's useful to have, sometimes we think a child's got a fever, possible infection, we'll give antibiotics, but there's actually quite a few more steps involved in that. And so when you're thinking about prescribing antibiotics, I think it's useful to understand such steps. The first question we always should ask ourselves is this child likely to have a bacterial infection? Do they need antibiotics at all? Because the first step in antibiotic prescribing is to decide whether they actually need them at all. And many children, of course, with infections don't need to have antibiotics. So we need to make an assessment of the likelihood of a bacterial infection. The second thing is, if we can, take some culture before giving antibiotics, because our ability to provide antibiotic stewardship depends a lot on whether or not we can scale down or stop antibiotics if a bacterial infection is not proven, or if in a couple of days we decide it's unlikely the child's got a bacterial infection. So even though I say we should take cultures before giving antibiotics, it's also important to, when a child has a severe infection, not to delay in giving antibiotics. I see many children for whom, because there's been a swing away from giving antibiotics for suspected viral infections, I see many children who have delayed administration of antibiotics when they have severe sepsis. That's a bit hard to distinguish between a viral infection and a bacterial infection, but because they have a delayed receipt of their first dose of antibiotics, they become much more severe and with multi-organ failure and other severe septic shock. So there is a golden hour, and we should try to start an antibiotic without delay when we recognise a severe infection. When you're starting antibiotics in any seriously ill child, you need to ask the question, have I got adequate source control? This is really important. Often as pediatricians, we start antibiotics, but we think, well, the surgeons will deal with source control, but actually it should be up to us to identify whether or not there's adequate source control. And what I mean by that is, if a child's got a collection of pus or inflammation anywhere that's infected, then that needs to be dealt with before the antibiotics can actually take effect. And I've looked after lots of children who've had collections of pus in their pleura or in their muscles or in their bones or their joints, and the antibiotics don't work until you've dealt with the source of the infection. So unless you drain the pus, unless you drain the empyema, unless you wash out the knee or debride the fasciitis, then the antibiotics, they start working. Day one for them is once you've got adequate source control. And I've looked after many children recently who've had a severe source of infection that, unless it's drained, the sepsis continues in a very severe way. And people wonder why, where they've had adequate antibiotics, but they're still not getting better. It's often because you've got inadequate source control. So we, as pediatricians, really need to look hard for any undrained source of infection, and deal with that as soon as we can. There won't always be, of course. Sometimes with severe infections, there's not an undrained source. It's a bacteremia or a pneumonia without a collection of pus somewhere, but we should always look for that. And that means looking clinically and sometimes looking radiographically with ultrasound or other modalities of imaging. Fifthly, we should choose an effective antibiotic for that particular infection, and that's why we have standard treatment guidelines, because not one antibiotic won't necessarily work on a different sort of infection. So choose the effective antibiotic for that particular infection. And then you need to assess whether there's potential for antibiotic resistance. Now, usually in community-acquired infections, say community-acquired pneumonia, there's not much potential for antibiotic resistance, but there are some high-risk patients and high-risk circumstances where there will be a higher potential for antibiotic resistance. And I would say that some of these include, for example, if a child's got multifocal staphylococcal disease, then there's a reasonable chance that the staph might be resistant to standard antibiotic therapy, because we know that community-acquired MRSA is quite common. Another scenario where there's high potential for antibiotic resistance is the child who's been in hospital for 3 or 4 weeks and has been on antibiotics, may have malnutrition, has been on prolonged courses of antibiotics, and then you know that if they get a new infection and they have severe sepsis, then there's quite a chance that they may have an antibiotic-resistant infection. And so we need to, when we're seeing a child with an infection, think, is there any potential for antibiotic resistance? And if there was, what would I do about it? Okay. We should choose an antibiotic or a drug that has adequate tissue penetration, and sometimes we should consider the kidney function. I don't think we consider this enough, but there are many antibiotics that are either toxic to the kidney, a few, not many, but there are some more antibiotics that, because where you've got impaired renal function, you'll have higher blood levels of the antibiotic, and that both those things you need to think about. We should aim ideally for a single drug with a desired spectrum of activity. It's not so good to be using 3 or 4 drugs to treat what is a simple infection. Ideally, a single drug, sometimes 2 drugs, very occasionally until you work it out, 3 drugs, but never more than that. I mean, it's extremely rare that you need to use more antibiotics than that, even in the sickest patient. 2 drugs often to start with, 2 antibiotics, but try to scale back to a single drug with a desired spectrum of activity for that particular clinical or microbiologically improved infection. We should, of course, ensure we give the correct dose and the correct route of administration, parenteral or enteral. And I'll talk a bit about that. There's new information about the value of changing from parenteral to enteral antibiotics once an infection's under control, but I'll talk about that later. But often in the earliest stages, the correct route of administration for severe infections anyway is parenteral. And then we have to have stopping rules. And I think often when we work in hospitals where there's a lot of bacterial infections, and in populations where bacterial infections are common, it's very hard to not give antibiotics when a child comes in and they're quite unwell with an infection. We shouldn't criticize any of our residents or registrars for doing that, for giving an antibiotic. But what we have to do is have rules for stopping and rules for scaling back antibiotics. Because if we, for example, give antibiotics for the wrong infection and we keep them going for 10 days, then there's a very high risk of bacterial resistance developing. Whereas if we give an antibiotic and the next day or the day after we see the cultures are negative and the full blood count doesn't look like there's a bacterial infection and the child's, not so unwell, then we can scale back that antibiotic or stop it completely, and then we've avoided the selection pressure that leads to high levels of antibiotic resistance. So there are ways even in environments where bacterial infections are very common, to limit the spread and the progression of antibiotic resistance by having stopping rules. So we'll talk about that as we go too. I wanted to say something about the most basics of choosing an antibiotic. And in a way, when a child comes in, we often don't know whether their infection, we haven't got it confirmed anyway, whether their infection is from a gram-positive or a gram-negative. But because that comes with blood cultures or other cultures later on. But based on the clinical picture, you can have a fair idea of what the likely infections are causing, likely bacteria are causing that infection. And so that's, in a way, that's the basis for the standard treatment. The basis for choosing standard treatment is our understanding of the bacterial etiology of different infections, whether it's pneumonia or meningitis or bacterial sepsis or urinary tract infections or otitis media or mastitis. We have an idea of what the likely bacteria are, the likely pathogens causing those particular infections. And we know whether they're more likely to be gram-positive infections or likely to be gram-negative infections. And what you'll see from this list is that for many of the antibiotics, there is some overlap. And there's overlap in the antibiotic covers both gram-positive and gram-negative infections. But for some antibiotics, there is only a spectrum that is a bit more narrow. They're more likely to cover gram-positive infections or more likely to cover gram-negative infections. And it's important to be able to make that distinction. And some of these distinctions, the narrower spectrum antibiotics, they've been intrinsically that way. They've always been that way. And for some, the narrowing of the spectrum relates to the development of resistance over time. In the last 30 or 40 years, some of these antibiotics have developed resistance. For example, penicillin developed high-level resistance to some gram-positive infections, so it's no longer useful for Staph aureus, for example. For no staphylococcal infections will penicillin be useful, but 70 years ago when antibiotics were first being prescribed, it was highly useful it was the way we were able to treat Staph aureus osteomyelitis, for example, whereas these days you would never try to treat Staph aureus osteomyelitis with penicillin. But in those days, in the post-Second World War period, it was possible, and it's the acquisition of resistance since then that has led to some antibiotics not being useful for some bacteria. Whereas other antibiotics, like aminoglycosides, because of their mechanism of action, have always been focused more narrowly as effective antibiotics against gram-negative infections rather than gram-positive infections. They have some activity against some gram-positives, but mostly against gram-negatives. So there is some logic in this list where there's some overlap between antibiotics that work well in gram-positive infections and gram-negative infections, but there are some antibiotics that are better for one than the other. I wanted to say something about how antibiotics work, and to understand how antibiotics work, I think it's useful to look at it a bit in reverse, and that is, what does it take for a bacteria to multiply and stay alive? Because if you can disrupt anything that causes the bacteria to multiply or to stay intact or alive, then that is an antibiotic. Anything that disrupts those functions will have antibiotic effect. And so, first and foremost, a bacteria has to have an intact cell wall or cell membrane. If that breaks down, if it becomes porous, then the bacteria will die, will disintegrate. So anything that disrupts the bacterial cell wall or the cellular membrane will cause the bacteria to die. And that's the basis for the first antibiotics that were identified, particularly penicillin. It disrupts the cell wall of bacteria, and by doing so increases the permeability, and that leads to cellular destruction. And that's why penicillins and their antecedents, their descendants, I should say, the cephalosporins and the carbapenems, are all bactericidal. They cause the death of bacteria. So there's a concept of bactericidal antibiotics and bacteriostatic antibiotics. And bactericidal antibiotics, they cause the death of the bacteria. And bacteriostatic antibiotics don't cause the death of the bacteria, but they stop the bacteria duplicating, replicating, okay? But anything that disrupts the cell wall increases permeability, leads to cellular destruction, and therefore it has a bactericidal effect. So the antibiotics that we use these days, the penicillins, whether it's benzoyl penicillin or flucloxacillin, or the cephalosporins, like third generation cephalosporins like ceftriaxone and cefotaxime, or cefuroxime or Keflex, they all, or it's the carbapenems like meropenem, they all have a similar mechanism of action. That is, they bind to the penicillin binding protein that's on the cell wall. They lead to a disruption of that cell wall, increase the permeability, and leads to the death of the bacteria. There are some antibiotics that don't disrupt the cell wall, but they disrupt the inner phospholipid bilayer, which is underneath the cell wall. And particularly that's polymyxin, which we don't use very often, but that disrupts the cell membrane as well. And it's also has a similar effect of increasing permeability, leading to cellular destruction. Therefore, it is a bactericidal antibiotic. There are some antibiotics that disrupt. Remember, I said that what a bacteria has to do to survive is to replicate and to have an intact and to stay intact. So to replicate, the bacteria needs to synthesize protein, and which is used for all cellular functions, and to replicate. Right. So anything that disrupts protein synthesis within a cell has an antibiotic effect. So the antibiotics that disrupt protein synthesis include the macrolides, so erythromycin, and also chloramphenicol, again another old antibiotic, but that's the way it disrupts. Also tetracyclines, and to some extent gentamicin and the other aminoglycosides. They disrupt the transfer of RNA to DNA to protein. That protein synthesis pathway that we all understand, that occurs on the ribosomes and in the cytoplasm of cells. If that's disrupted by an antibiotic, then it leads to the cell to not be able to replicate. So these antibiotics, the erythromycin, chloramphenicol, the aminoglycosides, in disrupting protein synthesis, they are bacteriostatic. They don't cause the death of the bacteria, but if a bacteria can't replicate, which they're doing all the time, they're constantly replicating, then the infection will come under control. Part of protein synthesis uses folic acid, and there is one antibiotic that disrupts folic acid. The effect of folic acid on the production, on the translocation of DNA to RNA, and that is cotrimoxazole. So Bactrim or Septrin, that disrupts folic acid synthesis. Methotrexate, also not an antibiotic per se, but also disrupts folic acid synthesis. So there's some other drugs, some other chemotherapeutic agents that do a similar thing. You can imagine that the effect is similar on cancer cells with methotrexate as what it is in bacteria with cotrimoxazole. So now we've learned that antibiotics function in several different ways to either inhibit the cell wall and break it down, or disrupt the phospholipid bilayer, or inhibit protein synthesis, either the translation of DNA to RNA or RNA to on the ribosomes to produce proteins, amino acids and proteins, or to inhibit folic acid synthesis, which also disrupts the translocation of DNA to RNA. So these are the mechanisms of action of antibiotics. And when we think about what things lead to antibiotic resistance, this is why it's important to know the mechanisms of action of antibiotics. So I want to get on to why resistance occurs. And I think the first thing to say is that because bacteria are replicating constantly, thousands of times every hour, bacteria will replicate. There is a natural random variation in bacteria. And in any population of bacteria, in any infection, there will be a large number of bacteria that are susceptible to the standard antibiotic. And there may be a few bacteria within that population that have some resistance genes just because of random genetic variation in duplication. And usually, to start with, a minority of the bacteria have those resistance genes. But if you give antibiotics over a long period of time, then and for which there is a subpopulation of the bacteria that have resistance genes, then those bacteria, those resistant bacteria, they evade the antibiotic and they survive and they multiply, and then they become what's called a resistant clone within the overall infection. So the sensitive bacteria are killed by the function of the antibiotics, but then you have a resistant clone within the infection, and that can develop resistance over time. And so sometimes when we get the sensitivity results of bacteria, if you've got a patient who's got a long-standing infection, they may have had it for 2 or 3 weeks, you might notice that the resistance pattern of the bacteria changes. It may go from being sensitive to all antibiotics within a 2 or 3 week period to being resistant to one or more antibiotics. And that's because of a resistant clone of bacteria that has evaded the antibiotics. And sometimes you'll have a mixed picture within an infection where some of the bacteria will be susceptible and some will be resistant. So that's a dangerous situation, especially if there's ongoing exposure to antibiotics, and that leads to a proliferation of that resistant clone. And that's called selection pressure. You all know about selection pressure in terms of evolution of various species. Usually that's to be more adaptive. And in some ways, the bacteria are being selected to be more adaptive to the environment where those antibiotics are being given. And that is a big problem in hospitals where there's large amounts of antibiotics being given. It's not such a problem in homes. That's why in homes and in communities, except when there's large exposure to antibiotics. And some of the exposure to antibiotics in the community can develop because of antibiotics that are used in other industries besides the healthcare industry. For example, in the farming industry, in some farms, in some situations, antibiotics are given, fed to cattle or fed to animals, and those antibiotics stay within the system and they get within the soil, and that can lead to high levels of community exposure to antibiotics and can lead to selection pressure on bacteria that are in those communities. And that's one of the reasons why we have community-acquired MRSA, for example, because of the widespread availability of antibiotics within communities. And of course, in hospitals, they can spread to other patients. So I just wanted to try to explain why antibiotic resistance occurs in hospitals and in communities, because it can help us deal with it. so I talked a bit before about the mechanisms of action of antibiotics, and by the same token, you can consider the mechanisms of antibiotic resistance. And remember, I said that what's important is the cell wall, maintaining the integrity of the cell wall. Well, and so that's the cell wall and the phospholipid bilayer, and maintaining the production of acids and proteins from DNA and RNA on the ribosomes. And many bacteria have acquired genes that allow them to evade the effects of those antibiotics. So, for example, there are some genes code for pumps that pump out antibiotics. So the antibiotic might penetrate the cell wall, but it's pumped out because of a resistance gene. So aminoglycosides, fluoroquinolones, tetracyclines, macrolides like erythromycin, they can all be subject to what's called efflux pumps that pump the antibiotic out of the cell. Sometimes there's a block in the uptake of the antibiotics within the cell. So tetracyclines, sulfonamides or cotrimoxazole and vancomycin, where you've got resistance to those bacteria, it's usually because of a block in the uptake of the antibiotics within the bacteria. And in some antibiotics, there are enzymes that inactivate the bacteria. These are perhaps the most important, and I'll speak a bit more about these ones. The inactivation enzymes within bacteria have led to a widespread resistance to penicillins and also to aminoglycosides and other antibiotics like rifampicin. And then there's some other blocks in DNA to RNA synthesis. So there are a variety of, there's not one type of resistance gene. There are hundreds of different genes that code for resistance in different bacteria, and they can lead to the bacteria developing resistance, and then because of clonal proliferation of those bacteria, they can lead to infections with those bacteria if they have ongoing antibiotic exposure. I wanted to talk about one particular form of resistance mechanism because it's perhaps the most important, the most consequential resistance mechanism that exists, and that is an enzyme called beta-lactamase. And if you recall in this last diagram, I said that there's one enzyme that's an inactivating enzyme, and the bacteria produce this enzyme and break down the antibiotic. And that's happened to penicillins and cephalosporins, and it can make them inactive. And there are many different types of these enzymes, but as I said, when antibiotics were first used, when penicillin was first discovered, it was effective against Staph aureus. And in fact, certainly the first child in whom penicillin was used was a child who had severe staphylococcal osteomyelitis and sepsis. And he was given, a young boy was given penicillin, and his Staph aureus infection resolved and he was cured. But it wasn't long before Staph aureus was resistant to penicillin because of an enzyme called penicillinases. So that happened in the 1940s, really within 10 years of the first prescribing of penicillin. And so then after that came a variety of different enzymes that are similar to penicillinases. They're beta-lactamases. So one called a cephalosporinase, which we recognize these days, a very important enzyme, extended spectrum beta-lactamase. That's a cephalosporinase because it breaks down cephalosporins. I'll talk a bit more about that. It's a very important enzyme these days. And more lately, in the last 10 years, what's an enzyme called carbapenemases. And they've become very dangerous enzymes that lead to resistance to even what you might think is the most advanced antibiotics. Now, initially, what was done to try to overcome the beta-lactamases was to produce different sorts of antibiotics. So from penicillin and flucloxacillin and amoxicillin came the cephalosporins like ceftriaxone and cefotaxime, because they weren't affected by the earliest penicillinases. But soon after, well, within 30 years, there was cephalosporinases. So they first started emerging in the 1980s, even before we had common access to ceftriaxone. In some countries where it was being used, the cephalosporinases developed. Then there was some efforts to produce antibiotics that would work against bacteria that even have cephalosporinases. And so some antibiotics like clavulinic acid with amoxicillin, what we call augmentin these days, or tazobactam with piperacillin. These are more, you would say, advanced antibiotics, but they're all developed to try to overcome these cephalosporinases. But they didn't last long. And as I said, in 1983, the first extended spectrum beta-lactamases were found. And they meant that they mostly developed in gram-negative infections. And we found them early on in the 1990s among Haemophilus influenzae type B, one of the commonest causes of bacterial meningitis. In the late 1990s in PNG became resistant to ceftriaxone. And that was a big problem in those days, as well as a number of other gram-negatives like Klebsiella and Enterobacter and some Pseudomonas became resistant to ceftriaxone. And that was because of this enzyme, the cephalosporinase, or what we call now extended spectrum beta-lactamase, the carbapenems. And later, what was developed was the carbapenems and amikacin. So if you've got an ESBL producing gram-negative like Klebsiella or Enterobacter, then the only chance of that being adequately treated is with a higher level antibiotic like meropenem or amikacin, or an antibiotic called tazobactam. Sometimes the fluoroquinolones like ciprofloxacin will work as well, but often not. But these ESBL producing organisms are mostly the enteric gram-negatives like Klebsiella, Enterobacter, sometimes E. coli. But they're mostly hospital-acquired infections. There's not too many ESBL producing community-acquired infections, but there are some. And as antibiotics become more widely available, we'll see more community-acquired ESBL producing gram-negative infections, I think. As I said, more recently, the most worrying thing is that there are a number of gram-negatives like Klebsiella and Pseudomonas and Enterobacter that are now even resistant to those higher level antibiotics, so meropenem, imipenem. And for those infections, there's very few other options. So it makes sense that we should limit the use of those higher level antibiotics to only those infections that are proven to be caused by those bacteria. There are some other different resistance mechanisms among these gram-negatives. So just to tell you, many of the gram-negatives we see are ESBL producing. If you get a Pseudomonas that's highly resistant, then sometimes it's not ESBL, but it may be another enzyme called metalloproteinases. They're the most common mechanism for Pseudomonas becoming resistant. And as I mentioned earlier, there is an increasing risk of MRSA, including community-acquired MRSA, and that's not ESBL in origin. ESBL is mostly in gram-negatives, and Staph aureus is a gram-positive. But there's a gene called MEK-A, the MEK-A gene, that leads to methicillin-resistant Staph aureus, or flucloxacillin or cloxacillin-resistant Staph aureus. And for those those bacteria, then our antibiotic options are rather limited. Vancomycin or clindamycin or rifampicin will often work against MRSA. But so I think the main message is that there are several mechanisms of action of genes that produce antibiotic resistance, and to know the common ones like ESBL and perhaps the metalloproteinases for Pseudomonas and the MEK-A gene that codes resistance for MRSA. As I mentioned, I first got really interested in this in the 1990s because we were seeing a lot of children who had extended spectrum beta-lactamase producing gram-negative sepsis, and not just from the hospitals, but also from a smaller number, much smaller number from the community. And mostly they were in children with malnutrition or newborn babies that were born in the village, and there were unsterile deliveries, etc. And what worried me at the time was that even though these infections weren't very common among pediatric admissions, they caused a lot of the deaths. And that was because in those days we had very few antibiotics to treat these multi-resistant gram-negative infections. These infections have not diminished since then. If anything, they've grown, they've become more common. And I suppose it's it's up to us to just recognize the potential for these clinically and with microbiology, and then work out in an individual patient and based on standard treatment what to do about it. The risk factors, as I said, in those days were if a patient had stayed in hospital for a long time, like many weeks or months, then they were highly likely to have resistant gram-negatives colonizing their skin or their respiratory tract. If they had severe malnutrition, if they had previous exposure to broad-spectrum antibiotics, or if they were village births with unsterile deliveries. And I think that those risk factors still hold up today. And we should, when we are seeing a patient, we should consider whether the infection is likely to be resistant or not resistant. And most infections, fortunately, won't be resistant. Like what I noticed back in the 1990s, with only 2% of our infections or our admissions had resistant bacteria, but they caused 25% of our deaths. So it's a minority of patients, but a majority of deaths. So we need to be able to recognize those risk factors for resistant bacterial infection and then act upon that. I just wanted, this is a more recent, I showed you some data from 25 years ago, but this is a much more recent case that I think is illustrative of the changes that have occurred. This was a young boy, a 12-year-old boy. He and his friends were doing a tattoo. I think you can actually see the tattoo on his arm. He just tattooed a little cross on his arm 1 week, and a few days later, he got a fever and a very swollen arm. It was the other arm that was swollen, interestingly, not the arm that was tattooed. And then he presented with lethargy and great difficulty breathing. And I think you can see from this photograph how swollen his left arm is. And the right arm with the tattoo wasn't very swollen. It wasn't, but he looked very unwell. I want you to consider what might be happening. What could be wrong? Can anyone suggest what the diagnosis might be? Well, if you think about what happened, again, sorry, someone wants to suggest?
Either cellulitis or osteomyelitis.
Yeah, very good. Yeah, most likely cellulitis or osteomyelitis. And remember, he's lethargic and he has difficulty breathing. So what could be so you've said cellulitis or osteomyelitis. Well, anything else?
Staph pneumonia.
Yeah, he could have, that's right. He could have staph pneumonia, couldn't he? And so that's, again, most of pediatrics is about recognizing patterns and about taking a good history and doing a proper examination. And I think you can see that if you have this history of a child who has a home-based tattoo, it's likely that any infection he gets from that might result from the skin flora. And we know that staph is a common skin flora. And so you're right that he had both cellulitis and osteomyelitis. And actually, he also had what's called a thrombophlebitis. His arm was swollen more because he had an infected blood clot in his arm. So an infected blood clot in the left arm that came from his Staph aureus infection. And I guess the reason why I wanted to show this case is because this is the sort of case for which we should think, is it likely to be a sensitive Staph aureus, or could it be a resistant Staph aureus? And as it happens at the moment, most children like this would be initially treated with cloxacillin or flucloxacillin, and it would cover most children. But there is high and I would say rising rates of MRSA in the community. So we have to be aware that if he gets put on standard treatment, which is flucloxacillin and perhaps gentamicin to start with, if he gets put on those antibiotics, it might be that he gets better, but it might be that he doesn't get better. And if he doesn't get better, then one of two things is happening. Either we haven't got adequate source control, that is, he's got an abscess or he's got a collection or a fasciitis or something that needs incision and drainage, or he's got MRSA, a resistant bacteria. And so when we are monitoring patients, we don't just put them on the first antibiotic and say, well, that's fine, their infection is treated. We have to follow them up and each day consider, is the infection responding to the antibiotics like I would expect it to respond? And do we have adequate source control? Now, as it turned out, this boy had MRSA, sepsis, and pneumonia, and thrombophlebitis, cellulitis, and osteomyelitis. So again, when you see Staph aureus in one part of the body, then think that it may be in another part of the body too, because staph likes to spread. Multifocal staph disease is common, and sometimes it can be due to MRSA. So when, after a couple of days, the blood cultures came back positive and he was started on vancomycin, then he got better. He didn't need source control because he didn't have an abscess that needed drainage, but what he did need was the right antibiotic for his resistant staph infection. This is another child. Again, this little boy had a bite, an insect bite on his eyelid. And again, just like a home tattoo, staph can get into that. And this was MRSA periorbital cellulitis. So again, just first of all, try to recognize the clinical infection that exists, consider what the likely bacteria are, and then ask yourself, could it be resistant or is it likely to be sensitive to standard antibiotic therapy? And so mostly it's right to give standard antibiotic therapy but monitor the response of the child. And if they're not getting better, it's either because there's inadequate source control, such as he's got an abscess behind the eye, or it's resistant. And again, in this case, this boy had MRSA as a cause of his periorbital cellulitis. So I think you know this, but MRSA is methicillin-resistant Staph aureus. It's only called MRSA because of sometimes we consider that multi-resistant Staph aureus. It's called methicillin-resistant because that's the initial antibiotic that was like flucloxacillin and cloxacillin. And from methicillin came the more clinically used antibiotics, fluclox and cloxacillin, but still a laboratory test with methicillin. And I guess when we see definite staph infections and we see abscesses or boils or cellulitis or osteomyelitis or complicated staphylococcal infections, multifocal staph disease, we need to think, could it be MRSA? And even when the child's coming from the community, often, hopefully, it'll be MSSA, that is methicillin-sensitive Staph aureus, but sometimes it'll be MRSA. That goes for whether the infection is hospital-acquired or community-acquired. In some hospitals, community-acquired MRSA is actually just as common as hospital-acquired MRSA because of these changes that are happening in the ecology in the community, the exposure to antibiotics, particularly through agriculture and other mechanisms, the free availability of antibiotics in the community. There is a certain populations that are at higher risk of MRSA, including people who have diabetes. They're at more risk of MRSA than others. And look, the reason I wanted to talk about MRSA particularly is that there is some pretty good data now from some parts of PNG, and particularly in the highlands of PNG in Kundiawa, that this is a good study from Kundiawa Hospital that looked at 70 children with osteomyelitis and found that MRSA was found, Staph aureus was found in the majority. 2/3 had Staph aureus as a cause of their osteomyelitis, and most were resistant to MRSA. So that's not to say that would be the case everywhere, but it certainly was in Kundiawa, where 85% of the Staph aureus were resistant to methicillin, and therefore resistant to flucloxacillin and cloxacillin. It's useful to know that the antibiotics that Staph aureus may still be susceptible to, and certainly an old antibiotic that we sort of has not been used very often in the last 10 or 15 years is chloramphenicol, and chloramphenicol now maintains some susceptibility to MRSA, at least some forms of MRSA. And back in the 1980s and 1990s, we used to treat osteomyelitis with chloramphenicol, and then chloramphenicol became less useful for meningitis. In fact, not useful at all for meningitis, but it's interesting that it might still have some utility in the management of osteomyelitis in the current era of MRSA. Also might gentamicin, interestingly enough, again, an antibiotic that has not been used as much as penicillin and flucloxacillin and even the cephalosporins. Look how resistant these ones are and how sensitive these ones are to the MRSA, at least in Kundiawa. So I just wanted to show you that as some interesting local data, I think. The other pathogen that we know is becoming increasingly resistant is Shigella. And I won't go through this too much, but we now know that, for example, that children who have dysentery are likely to have dysentery due to Shigella infections that are resistant to the antibiotics that we used to use, like cotrimoxazole and amoxicillin. So that's why standard treatment has changed. So instead of using cotrimoxazole or amoxicillin, then we're recommending ciprofloxacin for dysentery, because that's the only that's one antibiotic that will be effective against the Shigella that causes dysentery in children. And part of it is the widespread use of amoxicillin and cotrimoxazole over decades that's led to this resistance among Shigella in PNG and in countries all throughout the world, in South Asia particularly. I won't go through this too much, but this is an antibiogram that shows what proportion of different bacteria are susceptible or resistant to certain antibiotics. And it's useful to have this sort of data in your hospital or in your country? I'm sure you've seen antibiograms before, but for example, we know now that of the Staph aureus, almost all of them are resistant to penicillin and ampicillin now. Most of them are still sensitive to gentamicin and still sensitive more than half to chloramphenicol. But you can see the amber is increasing resistance, green is susceptibility, and red is high levels of resistance. Klebsiella, as I mentioned, has become resistant to most of the standard antibiotics that have been used. E. coli still retains some susceptibility to gentamicin. Salmonella species maintain some susceptibility to gentamicin and ceftriaxone. These sort of antibiograms differ from hospital to hospital, but roughly there is a trend towards more red and less amber and less green as resistance rises. I mentioned that sometimes it's useful to consider the tissue penetration of antibiotics, not so much in a standard infection, but when you've got a very severe infection, then it's useful to know that the antibiotic you're using penetrates well into the tissues where the infection is. This doesn't apply to many infections, but it does apply to very difficult to treat infections such as cerebral abscesses or lung abscesses. And there is some good data on the penetration of antibiotics in different tissues. I won't go through all that with you, but that's in a way why we choose antibiotics to be part of standard treatment, is that they've got good penetration for the infection that we're choosing it. So, yeah. I want to say to just show a couple of examples of how we can limit antibiotic resistance. And these are studies from hospitals where they tried to limit the use of higher powered antibiotics, particularly third generation cephalosporins. I won't go through this in much detail, but if you think that standard treatment in these hospitals was penicillin and tobramycin, which is a bit like penicillin and gentamicin, the alternative in this neonatal unit was amoxicillin and cefotaxime, and they found a much higher rate of colonization of newborn babies with resistant bacteria that had received amoxicillin and cefotaxime. So if you use more third generation cephalosporins, you will generate more resistance. Yeah. Cephalosporins are very useful for the management of meningitis and for proven gram-negative sepsis, but not very useful as standard antibiotic therapy. And so I see ceftriaxone and cefotaxime being used a lot, but all it will do if you use it outside its indications is to drive more resistance. But the best study I wanted to show you is a very recent study. This was only published this year. I did send it around to people. I thought it was a very, very good study where it assessed whether or not you could start with in neonatal sepsis. You could start with a standard antibiotic of IV benzoyl penicillin and gentamicin as initial therapy, and then scale back to amoxicillin or stop the antibiotics. And it showed that you could follow this treatment guideline where you started with effective antibiotics against bacterial sepsis in newborn babies, in septic neonates. And then you assessed whether or not the infant had clinical sepsis. If no, then the antibiotics were ceased the next day or at 48 hours. If yes, if they looked like they, on reflection the next day or the day after, if they looked like still they had bacterial sepsis, then their antibiotics were changed at 2 or 3 days to oral antibiotics if the cultures were negative. And if the cultures were positive, then the infant was continued on IV antibiotics until the infant was stable, and then they were changed to oral antibiotics. And what they showed was that you can de-escalate antibiotics in most cases where where if you follow this sort of guideline, you can de-escalate to oral amoxicillin, or you can stop completely, and it will be safe. They had very good outcomes from this from this, using this guideline, and it will generate much less resistance than 10 days of IV benzoyl penicillin and gentamicin, and much less than if you're using a third generation cephalosporin. So that idea of stopping rules or scaling back rules becomes very important. I think we should all have antibiotic stewardship programs, and they are coupled with infection control programs. And these are some principles which I think you all know. You can make a lot of gains in reducing antibiotic resistance by simply not giving antibiotics for simple cough or upper respiratory infections or watery diarrhea. That's the lowest hanging fruit, I would say. The easiest things to do are not giving antibiotics for those viral infections. You can increase focus on hand hygiene and using face masks and gloves and isolation of resistant organisms, perhaps. Certainly, I think we should be doing hand hygiene and using face masks a lot more. Not so much gowns and the isolation procedures we had with COVID. It's just too hard in many hospitals. But making the most of simple infection control measures, I think, is good. It's interesting how much other practices can influence whether or not we have rapid spread of resistance. And if we focus on enteral feeding patients, like properly nourishing patients, and reduce intravenous fluid exposure, then you'll reduce the infections that occur. Because you know that a lot of these infections that occur, the nosocomial infections come from drip sites. They come from thrombophlebitis or infected drip sites. And those things can lead to very serious infections. Many deaths occur because of widespread infections that occur from infected drip sites. We can change to using shorter courses of antibiotics to reduce exposure, and we can have, like I said before, stopping rules. It's okay to start, but stop if there's no evidence of bacterial infection, and that should be based on the clinical features and the full blood count. And I think I have in my hospital a weekly antibiotic stewardship round where we go through all the children on antibiotics and we decide whether they should stay on them, they should scale back. It's the same thing we should be asking on our ward round every day. Should we today, after 48 hours, the cultures are negative, the child's improved, doesn't look like a bacterial infection, we should stop the antibiotics or we should scale back. And that will help a lot in limiting this spread of resistance. Now, lastly, I wanted to say, often we think, well, how can we do this when we don't have good culture facilities, or how can we do this if we don't have other sophisticated tests like procalcitonin or CRP? How can we do it? Well, we can make the most of the full blood count. And I don't think we make the most of the information that we can get from a full blood count. We do full blood counts every day, but we don't look at it in enough detail to make the most of it. And I want you to, as throughout your training, become experts in the interpretation of full blood counts and the signs in the full blood count that tell us whether there's more likely or less likely to be a bacterial infection. And often we think about it very simplistically. If the white cell count's high, it's a bacterial infection. Well, that's not nearly as much information as we can get from the full blood count. There's so much more in the full blood count that can tell us whether or not there's likely to be a bacterial infection, and therefore we need to keep going with antibiotics, or we can scale back the antibiotics or even stop them. And if we can become experts in this, then we can have enough evidence to stop or scale back antibiotics, and therefore enough evidence to have a proper antibiotic stewardship program that's couples clinical assessment with the full blood count. And I just have written here all the things in the full blood count that make it more likely there's a bacterial infection. Now, of course, the increase or the decrease in the white cell count, sure, but it's predominantly an increase or decrease in neutrophils, like if you've got neutropenia or if you've got marked neutrophilia. But even more importantly, if you've got immature forms, if there's a left shift of the granulocytes to much more immature forms, like lots of band counts, lots of band cells, which are the immature neutrophils, or myelocytes or metamyelocytes, they're all the earlier stages of the neutrophils. Then it means the bone marrow's working overtime to produce lots of immature neutrophils. Or if the platelet count is extremely high, like 800,000, or if it's very low, that can be an indicator of a bacterial infection. And there's also this other measure called the red cell distribution width. If that's very high, then it suggests some inflammation like bacterial sepsis. And sometimes I've put this blood film because this shows exactly what you see, these measures. It shows these neutrophils that are very, I would say, very angry. They're very activated. They've got lots of lysosomes and enzymes in their lysosomes, and they're about to release them in an inflammatory burst. And if you see a blood film that looks like this is called toxic granulation of the neutrophils. Lots of neutrophils, and they look very toxic. And that's another situation where it's likely to be a bacterial infection. But even if you don't have the blood film, you can see it from these parameters on the full blood count. You don't need these other tests that may not be available. You need to be looking closely at the full blood count. In an antibiotic stewardship round, you can review all the patients who are on antibiotics. You can ensure that there's a clear indication written in. I think if we're starting antibiotics, we should write down what the indication is and whether there's a date to review or stop the antibiotics. That's important because otherwise patients get on antibiotics for weeks and weeks and nobody says we should be stopping this. We can check the doses are appropriate and they're appropriately adjusted if the patient's got impaired kidney function. We can check for drug toxicity, and I think we don't make as much as what we should about the potential for nephrotoxicity in these patients. We can review the clinical indications, the microbiology like the blood cultures and the inflammatory markers like the full blood count. And we can check that the antibiotics prescribed are consistent with guidelines, and we can make recommendations about scaling back or ceasing antibiotics. This is something you can do each week, and it can increase people's knowledge, I'd say, of antibiotics and their awareness of antibiotic resistance and what we need to do to limit it. So that's all I wanted to say about antibiotics and antibiotic resistance today. I hope that's been useful. As I said, there's so much more you could say about antibiotics, but I wanted you to have knowledge of the real basics of antibiotics and antibiotic resistance. So thanks for your attention today, and I'm happy to answer any questions that you might have.